I invite our first guest speaker, Dr. Dasari Harish sir, Professor, Government Medical College and Hospital, Chandigarh. He is requested to deliver the first lecture for the day on the topic Managing the Emergency of a Tertiary Care Hospital by Department of Forensic Medicine and Toxicology, GMCH Experience. Dr. Dasari Harish sir is currently working as Professor and Head GMCH Chandigarh, and he is also the Chairperson Adverse Reactions and Grievances Institutional Ethics Committee, Chairperson Exam Cell. He has about 34 years of teaching experience with 157 publications, and sir has been a distinguished fellow of ICFMT, fellow PAFMAT and IAFM, and President of Indo-Pacific Association of Forensic Odontology and the Joint Secretary, Indian Society of Toxicology, past editor-in-chief journal of INPAFO and IAFM, and he is also a state awardee. So please join us.
ये ऑन है ठीक ओके a very good morning. This is what I'm going to tell you. The managing of emergency of a tertiary care hospital by the Department of Forensic Medicine. Our experience in this. Now, before this, whenever we go and tell people that we are from the Department of Forensic Medicine, this is what the people tell us. We are postmortem doctors, cheed farke doctor, and somebody. But I have also seen one thing, that an appreciable amount of faculty, residents, and the doctors of this department, they are happy with this tag and enjoy this kind of recognition. Some go by the name of civil surgeon, some go by the name of medical legal expert, etc. But the network done by this department in most of the places in the country is just postmortem examination. Now we are slightly moving on into clinical forensic medicine, but main is postmortem examination for this department. But you know, forensic medicine, the scope is vast. You think of anything, even breathing, eating, whatever you think, forensic medicine will come into play. The air that you drink, the air that you breathe is polluted. You want to go and complain against the municipal corporation for pollution. Forensic people can come in between to test the various medical legal aspects. So that is there. Right from conception of a human body till late after burial, forensic medicine does come into play. And that is the scope of our subject. We always give opinion, and you know that any scientific opinion has to follow two different rules. One is the phrase rule and another is the Daubert's rule. Those who are pursuing forensic medicine PG, you should understand what is phrase rule and what is Daubert's rule. This is for your own good. These are the various fields in forensic medicine, of which at present the best is clinical forensic medicine. Now, PG in forensic medicine and toxicology started our institute way back in 2003, and in 2005 we applied to the administration to give us the casualty. We said we want the casualty, we would like to be associated with, and we took it in 2006. Day-to-day working and management of casualty by the department started in 2006. We had 6 sanctioned posts of EMOs. They were handed over to us, so our faculty strength also increased. In 2007, we made it mandatory or institute that internship, 15 days of internship should be in the Department of Forensic Medicine and Casualty. So since 2007, we are having interns for 15 days. It goes on round the clock. And because we had the casualty with us, faculty started taking keen interest in the working of the casualty. 2006 to 2009, we started understanding the working of casualty. We started giving opinions. We started helping the EMOs in the working. But we did not have a free hand in the working because, at least I did not have a free hand because I was not the head. I became the head in 2009. During this period, we noticed several gray areas and problems in the working of the casualty. And whenever you have some problem in your department, the best thing is to make SOPs, have them vetted by the authorities. We even gazette notify our SOPs. So all our SOPs are gazette notified, and then the juniors in the department who are working, they just have to show that this is the SOP of our department, and there ends the matter. So during the 18 years, that is 2006 to 2024, we developed number of SOPs to overcome this. Now this is the type of MLCs that we deal it. I have taken from 2018. As you can see, slowly the number of MLCs being dealt with by my department, they keep on increasing. We do around 1100 and sometimes up to 1200 MLCs per month. And these are the various ones. One of the most appreciable percentage of patients that come to us are from Punjab and Haryana. The worst is Punjab. Because after 2 p.m., Punjab's CHCs and PHCs, they have only one staff nurse. So what they do, they just load the patients in an 108 ambulance and they drop them at GMC. And we get ambulance loads of people from 4 p.m. till 9 p.m. usually. These are the cases: brought in dead 8%, sexual assault cases 3%, bites. These are the various percentages of cases that come to our hospital, distribution of MLCs. Now, these were the gray areas that we found out when we were working in the casualty. The most important one was what cases are to be labeled as MLCs and what cases are not to be labeled as MLCs. Then once you label a case as an MLC, how do you deal with them? Then there was a sort of scam going on in our hospital. These senior residents from the Department of Medicine, Orthopedics, Surgery, they would line up patients for CT scan and for others, and ambulances from private investigation labs used to stand in front of the casualty. They were loaded there and then they were taken to the private investigation labs for CT scan, for this, because the doctors would get a cut. And this menace had taken very huge proportion. Referral from various government hospitals, referral to other hospitals in Chandigarh, particularly PGI. One problem in Chandigarh is, for the people of Punjab and Haryana, there are 2 PGIs in Chandigarh, PGI 32 and PGI 12. So PGI 32 is particularly our hospital. GMCH is in sector 32. So they refer them to PGI 32. Patient comes to us. Our doctors cut 32 and send it to PGI. PGI refers it back, says PGI 32 is GMCH. So the patients just keep on doing a pendulum sort of thing. Administrative work, EMO after 5 p.m., EMO represents the MS of the hospital. He has all the administrative powers of the MS of the hospital, and the various ones that he has to deal with are Safai Karmacharis, attendants, then giving rooms. We have private rooms, allocation of private rooms is also for this, making poor free patients, ambulance service, everything comes to the EMO after 5 p.m. So he has a lot of administrative work to do also after 5 p.m. So all of this we had to deal with. The most important was that the EMOs, they had a discretion. The discretion was which case to label as MLC, which case not to label as MLC. Today, an RSA will be labeled as MLC. Tomorrow, the same EMO may label the same kind of RSA as a non-MLC. So there was a discretion. And when you have a discretion, money changes hands. And that is one problem. Second thing is, the relatives of the patient will start fighting with you. Uski to aapne MLC banai, meri MLC nahi banai. And the EMOs used to practice one thing, that they would ask the patient's relatives to write ki, mujhe EMLC nahi banwani. And when they would say, mujhe MLC nahi banwani, then they would not treat it as an MLC. So we had to somehow remove this, and we had to put an order. This was the most important case that we had to deal with, and after that we put our foot down and said, no, we'll have to give the list. A girl was brought from an orphanage in Mohali. She was brought in dead. The owner of the orphanage was adamant that this case should be a non-MLC. Brought in dead, again, was at the discretion of the EMOs at that time. You could make a brought in dead MLC, you could make a brought in dead non-MLC. It was at their discretion. So when this chap became adamant and when he started threatening the people, EMOs and others, then the EMO called us. We examined the body. We found out bruises on the neck, and there were certain multiple bruises and throttling marks. So we showed this to the police. Police at that time, they were with the owner. They did not want this case to be an MLC. So police, when we showed them the marks, the police, they took a back step and we made it an MLC. After MLC, when we examined the body completely for postmortem examination, we found out that this girl was tortured. There were signs of sexual assault, and she was throttled to death. We informed this to the police seniors. They brought in the people. The involved police persons, they were suspended. This person was put behind bars. Orphanage was closed. And this time, we said that we have to come out with an order. This list of cases is given in the first medical legal manual prepared by the IAFM. This is IAFM's manual. And this is the exact replica of the IAFM manual. This lists the number of the various cases that have to be made an MLC. And if you say, first thing is all cases of injury. We make, even if you fall in your toilet and come to our hospital, that will be an MLC. On way from your ward to the another ward, if you slip inside the hospital and fall down, it will be an MLC if you come to our casualty. So every injury, whatever, will be an MLC. All cases of burns, you can see this list. And brought in dead cases. Brought in dead? Here. G. All brought in dead is an MLC in our institute. And then we had this, we got this order approved by our director principal and we put in our gazette. In Chandigarh, gazette notification is easier. You just have to get it approved by the director principal and send it to the UT through the LR, legal remembrancer of UT. If we approve it, it becomes an gazette notified one. So here itself we have said that as you are a government servant, you do not require anybody's consent to take to prepare this case as an MLC. Information to police and labeling the case as an MLC is your duty as a government servant. You do not require anybody's consent. And then we said that after preparing this as an MLC, after informing the police, because you cannot do a medical legal examination, you take the informed consent of the patient. The patient may or may not give you consent for a medical legal examination. Then you take the patient's medical legal informed refusal and do not touch the patient. So this is what we said, and this was way back in 2010. Then we had another problem. Surgery, medicine, gynae-obs, they would collect the samples. Surgery would collect bullets or pellets. Orthopedics might collect something. Gynae-obs might collect something. And they would send these samples through the attendant to the MO to seal. We said, what the hell is happening? And we got an order through our MS. We said that every department which retrieves a sample will seal the sample with its own seal and will itself hand over to the IO, and Department of Forensic Medicine will not come into play. So this was the second one. Same thing about MLC. And in 2011, June 2011, we started computer typing MLRs. Since 2011, we do not have handwritten MLRs. We have computer typed. There was one case in the Honorable Punjab and Haryana High Court, Lab Singh versus Lab Singh and another versus some state of Punjab, I suppose. In that case, the justice was Justice Pradeep Bindal sir, and Justice Pradeep Bindal said in 2012 that no MLR in Punjab, Haryana and Chandigarh will be prepared by hand. They will all be prepared online, and we developed a software which is known as the MedLeaper software, but that was in 2013. Since 2011, we have been preparing all our MLRs computer typed. Again, this is still going on about the patient's MLR. Now what we do is, if a patient gives an informed refusal, we do not prepare MLR obviously, but we have instructed all our EMOs, all our residents, that when you do a medical legal examination, take complete notes, history, investigations, all injuries, whatever you do on the observation file. And we said that this observation file should be absolutely complete. So when we have an informed refusal and then the police comes to us, because I have seen number of cases. Today I will say I don't want an MLC. 4 days later I will myself go to the doctor and tell him, give me an MLR. How do you give an MLR to a person who has refused consent for a medical legal examination? Or he will go to the police, register, get a case registered, and the police will come to you for a copy of the MLR. This happens, always happens. Even now it is happening. So what we do is, to save the police and help the court, we give an attested copy of our observation file, and we tell the police that even now if you want an MLR, you bring the patient, we will take consent for today, and we will examine the patient as of today, and we'll prepare the MLR and compare them with our injuries, and then we'll give the opinion. So this is what we do, and this has been accepted because we have been doing this for the last 6-7 years. This has been accepted in all courts in Chandigarh and wherever we go. Then we have a Right to Service Act in Chandigarh. Right to Service Act says that if I give you an application for any medical legal document, you have to provide me within 72 hours. So we do everything as such. Then our Department of Anatomy, one case, Department of Anatomy was they wanted, and without our knowledge, the Department of Anatomy put one brought in dead case into our freezer. The moment we came to know, we made that an MLC. Now Department of Anatomy could not retrieve that body from us, and the relatives started having, altercations and fights with the Department of Anatomy. Finally, the Department of Anatomy cut a very sorry figure, and we had to perform autopsy on that because the police was not willing to release the body. So this is after that. We said that no body will come to the mortuary directly. All bodies which have to go to mortuary will come through the emergency, through the EMO, and we will make these an MLC. This order I took out in 14. We stopped this, and when we stopped this, I had to face a lot of people from the private labs. They even came to the department to threaten me with dire consequences if I did not restart the investigations. The main was Atulya lab. It is in sector 34 of Chandigarh, and they sent their henchmen to threaten me to start this, but we did not, and I informed SHO 34, and after that this stopped. But now private labs, what they do for smaller investigations, they have their own people coming to various wards, and that menace we are not able to stop. Then contractors. This is another problem that we faced. Contractors. You have to send 10 people for emergency duties, 10 attendants or 10 Safai Karmcharis. They will send 4 or 5 and they'll take attendance for the 8. And then this scam was noticed by the accounts department, and 2 or 3 of our EMOs, they have faced a lot of problem, but somehow we came and we were able to convince the authorities that what the EMOs do, they do so in good faith, and this was a mistake. So they were let off with warning, and after that we stopped. We said only that EMO will sign who has physically seen this person working and who has the attendance sheet with him. So we stopped this. Good Samaritan Act, we know Good Samaritan Act has come. Anybody who takes a patient from roadside to the casualty, we will not ask any details regarding that Good Samaritan, and we will not force him to be a witness to our medical legal examination. And we also tell the police not to harass the Good Samaritan. So this was the Good Samaritan Act, where we sort of help these people who bring the patients to us, so that the people, the Good Samaritans, they are not harassed by police and others. Again, even though we have a lot of these orders, number of times the most important problem that always comes up is labeling a brought-in dead as an MLC. The patient says that my father was alive in the house. We were bringing on the road, on the way he died. I have the papers. Why are you making this an MLC? And this problems comes. And sometimes people approach the MH, people approach the director principal of our institute. They ask us to make this a non-MLC, and we flatly refuse. So what happened was, the MS of our hospital at that time, he constituted a committee. The committee was one sitting judge in High Court, another member was the SP of the hospital, The third was the MS himself, and fourth was representative of the Department of Forensic Medicine. And when this was known to me, then I went to this. There were around 6 or 7 sittings, and I said, my EMOs are all MBBS. They do not know the intricacies of medical legal cases, and I will not give them any gray area. I'll only give them black and white. I said, you give a written order that this case will be labeled as a non-MLC on the orders of the MS. I said, you take the onus from me. You say, prepare this as a non-MLC. We'll do so, and tomorrow we'll show the court that this order is from Dr. So-and-so, the MS of the hospital. The MS said, how can I do it? Then I said, how can we do it? We will not do it. And so, this went to the Legal Remembrancer UD Chandigarh. And Legal Remembrancer UD Chandigarh came with a list of 18 cases where the case will be an MLC. And in this, one case he said was all brought in dead cases and all cases of death in the hospital within 24 hours where the doctor has not been able to establish the cause of death. So, we had now a more leeway than what the doctors wanted. Up till 24 hours, we could label a case as an MLC and brought in dead was included. So now we tell our EMOs that whoever says anything, you say this is the UT administration's order that this case will be an MLC, and this has stopped most of our problems regarding brought in dead cases. Consent and MLE, I have already told you, medical legal examination, we have already told. In 2016, we started the one-stop crisis center in our institute. This was inaugurated by the Honorable Advisor to the Administrator. Now, OSCC, you know, is the aftermath of the Nirbhaya case, and the Honorable Court said that every institute should have a place for examination of the sexual assault and domestic violence survivors. This is for OSCC is not only meant for sexual assault, this is meant even for domestic violence cases. If the survivor comes to the OSCC, then she will not leave the OSCC for any investigation, any consultation, any FIR, anything. She will sit in the OSCC, all people will come to her. And this is what happens in our hospital, that she comes to the OSCC and first she will go to the EMO, EMO will register the case, EMO will send an attendant, inform the gynae ops department. And because in Chandigarh, Punjab, Haryana, again we have a UT order, we have an honorable High Court order which says that no male doctor will examine a female survivor of sexual assault. This is way back 2003, sir. Kab ke? 2003 order. So we cannot examine. So the OSCC is with gynae ops. We send our PGs because PG has to do medical legal examination of sexual assault. He doesn't do the medical legal examination. He assesses the doctor, and the name will be the doctor as well as our own PG who will be assisting. The examination is done by the senior resident of the Department of Forensic Gynae Ops. So all cases of sexual assault come to this place and they are done here. This is our OSCC. Then we do have some cases where the relatives, they are not able to pay the fee of the hospital, and so they just abandon the patient and leave. So we said that whenever a patient is unattended, then the staff nurse, the nurse in charge, will report to the security and to the authorities. we will search everywhere in the hospital for up to 3 or 4 hours. Then we will inform the MS, and if the MS says that this case will be now abandoned patient, then he becomes an unknown and a destitute, and unknown destitute becomes an MLC in our hospital. So we then convert this case into an MLC. Now, as I told you, administrative works, power free. Power free is previously what happened was when we saw so many cases, a person is coming with a gold chain, a gold bracelet, and he is known to the HOD of one department. He is getting down from a big car and he will say, "Mera car poor free kar do." So we said that we require documents, and these are the we have certain you should have a BPL card, poor free income certificate, and others. And only when you show you these will the EMO make it poor free. EMO has the right to make a case poor free only for 24 hours. After that, it is the head of the department where the patient has been transferred. That department will make it poor free, but EMO will collect these documents and will inform the office of the MS. Allotment of rooms, same problem. Because in our hospital, there is a waiting list, and then there are VIPs. VIP will get the room first, then the people who are in the waiting list, number of times. And sometimes what the EMO does is he gives that room to his own relative who he thinks is the VIP for him. So to get away with this, we said EMOs will not allot private room telephonically or anything. The senior resident or the assistant professor of the of that ward will specifically sign the request letter, and without the signature, we will not give any room. And even then, he will have to inform the MS or the office of the MS before allotting the room to the patients. So, for free private rooms, this was another problem that we used to face. Then, unknown patient has come to your ward. You have to perform a surgery. They would send their resident doctor to the EMO that you sign the consent form. But then we said that no, the consent for a unknown patient, it will go down to the respective HODs from the office of the MS, and the respective HOD can give it to whomever he thinks. So now we stopped signing consent forms for all unknown cases. We said the respective HOD will do it or the hospital will do it. We will not sign the consent for unknown. Mass disaster, we have a mass disaster committee. Previously, when I was the chairperson of the emergency services, I was the chairperson of mass disaster committee along with the MS. Now, I am not the chairperson, but we have a committee. EMO will have to inform the head of the committee and it will go off. Then this is a very, always a problem, unruly patients. We have tried so many things, it is not happening. Now, because of that RJ Kar hospital case, we have come up with SOPs, but this is how government works. It will take time for a panic button to come, or for face recognition rooms to come, or for anything. It will take time. So, but we now have a rapid response team. There, whenever the hospital, something is happening, 5 good people, athletic security guards are there. They will come and they will sort of take over. And of course, we inform the police. Police comes. Then finally, this is the one. Yesterday, when Dr. Jitendra Jakad was presenting his case, I was talking about XYZ patients. We do not register, we do not name, register the name of any sexual assault survivor. All sexual assault survivors are XYZ for us. XYZ care of Punjab, XYZ care of Haryana, XYZ care of Chandigarh. This case will be XYZ. This case will then go to the SR of Gyneops. SR of Gyneops will take the identity proof, Aadhaar card or anything, and the SR Gyneops will then sign saying that I have seen the photocopy and the original, and the photocopy is with me. She will seal it and put it in the uh, department. This identity is there. So XYZ with CR number so and so on such and such date, we know the identity. Nobody in the hospital will ask for any identity proof from the patient anywhere. All investigations will be done like this. The MRD can prepare birth certificate and death certificate by opening that seal, because birth certificate you cannot have an XYZ birth certificate, death certificate you cannot have a XYZ death certificate. So when MRD has to prepare a birth certificate or a death certificate, it will open that packet, find out the patient, make the proper death certificate or birth certificate, reseal the whole thing, and will give it to the authorities. This is what we have done for XYZ patients. So this is in brief the working of our emergency, our role in the emergency of GMCH. Thank you.